and we are recording now. Again, everything will be up on box.com. I had sent out that link. Maura sent out that email as well. If you don't have that, let me know. Unfortunately, I am still working with Echo and Box to try to get that issue sorted out with uploading the videos. But we're going to find a workaround and make sure that gets out to everybody. And if there are any questions, as always, feel free to type into the chat. Any points to discuss, feel free to raise your hand if you're on video. If you have your phone, you can use *9 to unmute, *6 to unmute, *9 to raise your hand. All right, so I'm Jevin, the PA with the Survivorship program.
I'm Angela, the clinical social worker.
Ashley, one of the HEMOC fellows. Angelique, the program coordinator.
I'm Reed, I'm a graduate student.
I am Tara, I'm the director.
I'm Scott of the PT.
And Maura, the dietitian.
All right. I guess just before we jump into the presentation, any questions before we get started? Feel free to use the chat as well. Okay, so I'm going to go ahead and share the screen. We'll get going with late effects. All right, so Jevin here again. Just going to be starting with peripheral neuropathy. Peripheral neuropathy is defined as nerve-related pain, numbness, or tingling that can affect the nerves, oftentimes in the hands and feet. That could be a treatment-related side effect from chemotherapy and or radiation therapy. Associated symptoms can also be swelling, cold sensitivity, or even muscle weakness or cramps. And you might recognize these numbers from the previous slideshow on Survivorship 101, but the prevalence is quite large. From acute, subacute, or chronic symptoms, it can range from 19 to 85%, depending on the treatment received, of survivors being affected, and can lead to permanent symptoms and disability in up to 40% of cancer survivors. In particular, peripheral neuropathy is not curable, but it is certainly manageable. The reason why it has that what's called a stocking glove distribution affecting the toes and feet and then the fingertips and hands is because the nerves that are affected are length dependent. And so oftentimes you have large nerve fibers being affected that can lead to issues with proprioception or the ability to sense movement or position, vibration, and light touch. And when small fibers are affected, it can affect things like pain and temperature. So that's why you see these range of symptoms that can be associated with it. In particular, you can do certain assessments to check for this. Certain testing includes nerve conduction velocity testing to look at how the signal is being transmitted from the nerves. And you can also do an electromyography looking at muscle function as well to determine if there's a related nerve or muscle disorder. So peripheral neuropathy, as I mentioned and alluded to before, chemotherapy and radiation can be causes for it in this setting. For radiation therapy, the mechanism is not well understood, but it could be related to blood vessel injury, radiation fibrosis, and nerve compression at the areas where the radiation took place. But when we think about that stocking glove distribution, oftentimes we're thinking about the chemotherapy-induced peripheral neuropathy, and there are a number of agents that can cause it. Platinum-based chemotherapies like cisplatin, carboplatin, oxaliplatin, vinca alkaloids like vincristine, epothalones such as ixabepilone, taxanes like docetaxel or paclitaxel, proteasome inhibitors like bortezomib, and immunomodulatory drugs like thalidomide. And the associated incidence is there on the screen as well for you to read. Just a quick comment on a few of those. Oxaliplatin, one of the platinum-based therapies, is highlighted. One of the hallmarks is cold sensitivity. Paclitaxel, as well as oxaliplatin, can occur with symptoms shortly after treatment. The thing to remember about chemotherapy-induced neuropathy is that it's often, it can be short-lived and can be dose-dependent as well. So that's something to keep in mind, that in a lot of cases, it does resolve shortly after treatment. However, as I mentioned before, it can be a long-term lingering effect for survivors. And it's also important to mention that there are a number of other causes for peripheral neuropathy as well that present similarly. Nerve injury or pressure on the nerve, diabetes. As a matter of fact, 60 to 70% of those with diabetes have peripheral neuropathy. Vascular conditions leading to poor blood supply, like atherosclerosis, and autoimmune disorders, which cause autoimmune attack on the nerve cells, like Guillain-Barré syndrome or Sjogren's, for example. Rheumatoid arthritis is another. Cancer-related pain can also affect peripheral neuropathy, or cause peripheral neuropathy as well. Things like mass effect from a tumor and paraneoplastic syndromes. And though they're rare, they can indirectly cause nerve damage through, again, immune attack. Infection is another potential cause for peripheral neuropathy, with things like herpes zoster or shingles, West Nile, cytomegalovirus, things that you think about in immunocompromised patients. And rarely genetic causes as well, like Charcot-Marie tooth.
So as Devin was talking a minute ago about the assessment, yes, we have the nerve conduction velocity test that we can do, in a more a clinical setting, especially for any of the rehab professionals that may be out there. We have a variety of ways that we can assess peripheral neuropathy as well. We will start with a subjective questionnaire. Some therapists will use the total neuropathy score, but we really will try to get into as well, trying to assess the level of loss of proprioception, the loss of protective and light touch through filament testing. And I know this may be hard to believe in this modern day of medicine, but one way that we can assess peripheral neuropathy very, very simply is by using a tuning fork. There are actually normed references as far as if you strike a tuning fork and you place it on the patient's wrist or their ankle, and you ask them to close their eyes. You say, "Tell me when it stops vibrating." And if they tell you that it stops vibrating before it actually does, that indicates that they have a loss of deep sensation. So, and then more functionally for those of us in rehab, our occupational therapists are going to assess the hands as far as functional dexterity tests and that sort of thing. And as a physical therapist, one of the things that I'm cued into, if somebody has peripheral neuropathy in their feet, if they have loss of sensation in their feet, they're a falls risk. They don't know where their feet are. So we're going to be screening for balance as well to see what their balance is at that point.
Thanks, Scott. Jevin here again. Just wanted to review some of the treatment options associated with peripheral neuropathy as well. First and foremost, what I think about is protection and considering the impact on quality of life. And as Scott had mentioned before, balance can be a big issue in this population. You'll see on the screen I have a picture of someone walking on a rock, perhaps on the beach, it looks like. And something that I think about is protecting the feet because of the numbness associated with this. Some people might have that padding-like feeling on the bottom of their feet or not be able to feel anything because of neuropathy. So always making sure you're asking patients to check their feet on a daily basis when they're maybe getting ready in the morning or putting on their shoes or socks in the morning, watching for things like lacerations or abrasions, anything that's a break in the skin that could lead to infection that maybe they wouldn't notice because of their numbness that they're having. And then again, the impact on quality of life, their ability to get around. And so kind of going back to some of Scott's comments there, getting PT or OT involved, if it's significant enough where it's impacting them on a daily basis, and their ability to get around is an important consideration. Things like holding on to items with their hands, if they're having trouble fine motor functioning, buttoning buttons, zipping zippers, tying shoelaces, dropping items, and so on. The other thing that I think about a little more conservatively is the use of B vitamins. B6 at 100 milligrams a day, B12 at 1,000 micrograms or 1 milligram a day. The thing about the B vitamins is that they help with neurotransmitter and neuronal membrane synthesis. So they can be beneficial in those who have had nerve-related damage from treatment. And anticonvulsants are another option, gabapentin and pregabalin. Tricyclic antidepressants, nortriptyline and amitriptyline, have been used historically. There are a number of side effects that can be associated with these. Sort of a less favorable option at this point in time. The SNRIs, duloxetine and venlafaxine, traditionally used for as antidepressants. I'll get back to that in a moment. Acupuncture and other complementary therapy options as well. Acupuncture has been shown in some small studies to have benefit for chemo-induced peripheral neuropathy, but more studies need to be done to prove reliability, and larger studies as well, comparing the placebo as well as sham acupuncture, where they don't penetrate quite as deeply with the needles that they use. And they do it in spots that aren't at the same point on the body as real acupuncture. So those are other options as well. The thing to keep in mind with acupuncture is that it's not always covered under insurance, so be very mindful of that. Going back to the duloxetine, a quick point to make there is that this medication in particular is recommended by ASCO. There are no other recommendations for any of these other options here, but they have been used as well. So duloxetine is often a good place to start if it's tolerable for the survivor. And then, of course, as I mentioned before, physical activity and then sensitization exercises, as Scott will talk about a little bit more as well, can be beneficial for those with neuropathy.
So actually, Jevin, right before I get into that, a question did pop up.
Okay.
Are B6 and B12 levels tested prior to supplementation or started based on symptoms? And or you were just saying that it's not usually tested ahead of time.
It's usually just based upon symptoms.
Yeah, so they usually are based upon symptoms. Something to note is that chemotherapy can sometimes lead to B12 deficiencies. Watching for anemia, of course, that can be something to consider. While keeping in mind that chemotherapy itself can lead to anemia, just the side effects from myelosuppression. But usually it's based on clinical suspicion. That was a great question. Thank you.
So again, I have to say that, again, there is no cure for peripheral neuropathy, chemo-induced peripheral neuropathy, but there is a lot of emerging research showing that the benefit of exercise. Right now, a combination of cardiovascular exercise as far in conjunction with strength training and balance training. There isn't a lot of research yet on these whole sensitization exercises, but when I speak with my occupational therapy colleagues who get more of that sensory training in their schooling versus what we get in our physical therapy training, there's definitely something to it. And so I will always include some sort of sensory diet, so to speak, in our approach to peripheral neuropathy. So exposing different textures to the fingers and to the toes. Obviously nothing sharp or abrasive, but like a shower loofah, like a piece of felt or a piece of corduroy, easy things that people can find around the house. And again, I have no research to back this up, but I have a lot of patient report coming back that a lot of patients will actually soak their feet in Epsom salt, especially at nighttime. A lot of patients will report that the neuropathy is bad at the end of the day, and they'll try to get into bed and they put the sheets over their feet and it just sends them right through the roof. And so I'll tell them that to just sit on the edge of the tub and put some warm water with some Epsom salt in there for a couple minutes and let your feet soak, even if it's just enough to take the edge off. May help with symptom management there. But again, as far as hand strengthening and foot strengthening goes, we'll put together a home exercise program for that. And again, in a clinical setting, we're going to really address balance, all of our different techniques that we have as far as working in parallel bars and on the Bosu ball and all those kinds of things to really challenge the balance system and really try to get the person to be more aware of where their body is in space.
What's fluidotherapy?
Oh, so fluidotherapy, Oh yeah, I don't have that slide up here. It basically looks like R2-D2's distant cousin for all you Star Wars fans out there. No, but what it is, it's a contraption that actually that the patient can put their hand or their foot into, and inside the contraption is actually it's ground up corn husks. It's not. It looks like sand, but it's actually ground up corn husks, and it's very, very fine. And when the patient puts their hand in there, when we turn the machine on, it warms up, and there's a blower. So it basically blows around the corn husk so that it gets the hand or the foot gets total immersion in that device. And we can put the temperature up to 95, 100 degrees or whatever. And a lot of times we'll do that before we even move to our therapeutic exercise. And patients say that their hands feel amazing after they do that. Not every physical therapy clinic has one of these. It is kind of an older piece of equipment, but we have one here at Yale New Haven, and like I said, our patients love it.
Wow.
It's really cool. Before we move on to lymphedema, the team from UConn asked the question, if the patient would benefit from duloxetine, do you refer them back to their PCP or their oncologist for prescribing and monitoring?
So typically, at least in our clinic, medical oncology will usually be the ones to prescribe, since it's treatment-related side effect that they're having. I think if there's a conversation with the primary care provider, it could certainly go to them as well. But typically, medical oncology would be the one to prescribe it. And just a quick comment on that too. The ASCO recommendation for duloxetine comes from the fact that it's been studied and it showed, versus placebo to be beneficial in reducing neuropathy-related pain. So that's why that recommendation is there. But definitely a good question. Thanks, Sarah and the team from UConn.
Okay, so to take a couple minutes to talk about lymphedema, and while I'm not a lymphedema certified therapist, I work with a great team here, and so I know that I will refer to one of my colleagues who's lymphedema certified, and we make a lot of referrals to lymphedema treatment through our Survivorship clinic. And so, if you have somebody in your clinic who may be experiencing lymphedema, if they have a history, especially for our breast cancer population, they have a history of axillary lymph node dissection and radiation therapy. These are some questions that you want to ask, kind of leading questions as far as, how is your arm feeling? Have you noticed any changes in how, your watch or your rings are fitting? And really be cued into certain words that the patient may use, such as, my arm feels heavy, or my arm feels fatigued or tingly, or even just weird. These should all be words that should cue you in to that maybe that this patient may need further follow-up for lymphedema assessment.
And can I just make a quick comment too? The breast population, it's so relevant, but then, you think about some other areas too, things like head and neck, things like, any gynecological related cancers where they've had pelvic node dissection. So it's always important to keep in mind things like neck swelling too, leg swelling, and as well. So
absolutely, yeah, very good point. And so, Jevin, actually, to your point there, which goes into the next slide, it's interesting. There actually is not a great way to assess head and neck lymphedema. I know that the lymphedema gurus in the world are still trying to come up with a really good assessment of head and neck lymphedema. As far as upper extremity and lower extremity lymphedema assessment, though, we do have some better measures for that right now. The gold standard is either water displacement or using circumferential measurements. But some clinics may have other pieces of device, such as a SOZO or a perometer. So it all depends on where your clinic is and what your resources are. But I would even say too, and this is kind of a plug for prehab, that for any patient who we know is going to be having any kind of surgery that's going to involve lymph nodes and any kind of radiation that may follow, I would advocate to have somebody get screened even early on before they even have surgery, so that you truly have a baseline of what this patient is like. Because so often when somebody develops lymphedema after the fact, they will compare the involved upper extremity or the involved extremity to the other uninvolved extremity, but that's not truly comparing apples to apples. So if there's a way that you can get some sort of pre-surgical or pre-radiation assessment, then you can truly know what that patient's baseline is. There's been a lot of discussion over the years as to what exactly are the precautions for lymphedema, and I think that some of these precautions can make some of our patients anxious as far as what they can and can't do. What's up on the slides right now are actually from the National Lymphedema Network, as far as maintaining good skin care and healthy lifestyle and medical checkups. So those are all pretty basic things that our patients can do that have shown to be pretty reliable. And again, one of the things I want to highlight here is trying to avoid prolonged inactivity. I'm going to get to in a second the Kate Schmidt's article that came out a couple of years ago, where the conventional thinking used to be that we did not want our patients who had lymphedema to move, or that had a lymph node dissection to move and to lift any significant weights. And we now have been able to debunk that, which is great. And so what we find is that activity is actually one of the best prophylactic things that we can do to have our patients try to avoid lymphedema. When it comes to things such as constriction, as far as blood pressure cuffs or needle sticks and that sort of thing, there actually is not a lot of research to back that up. Just like with air travel, there is actually no clinical trials that are out there that say definitively yes or definitively no, do these things cause lymphedema? So we can tell our patients that, as a guideline, this is what you want to follow, but we also need to impart on our patients that if by some chance they do get a blood pressure reading on their involved side, that they're not automatically going to get lymphedema. So we need to be able to educate them to let them know that, good skincare is one of the best things you can do, and weight management is a really good thing to do, but some of these other things, we don't have the research to back up definitively yes or no.
The top two risk factors, right, are infection and BMI.
And BMI, exactly.
So as we move forward in time, and in our overweight and obesity epidemic, those are going to be really important risk factors to address. But going on a long flight, we used to tell patients they needed to wear a sleeve prophylactically. Patients didn't go places because they didn't have a sleeve, so they were afraid to fly. And still to this day, patients are, take a lot of precaution to avoid blood draws in that arm, blood pressure in that arm. But if you're a 20-year survivor and you have no more veins in the other arm, it's okay to have a blood draw. Like you said, Scott, the science that's been looking more recently have not found that to be an actual risk factor. So while we don't say absolutely you can have as much blood drawn as you want, we also say that you don't have to be so concerned. Although the nurses and the people doing the blood draws often refuse to draw the blood on those arms. So it's going to be, I think, another generation before we really see those measurements adopted by the healthcare providers.
Yep, absolutely. Yeah, very good point. So again, we have these existing precautionary guidelines, but there's not, they use the word paucity. There's really no scientific evidence to back this up. However, what we do have for science to back us up is the study by Katie Schmitz and her team. I'm saying a few years ago, I guess like 10 years ago now. But this was landmark because truly, again, our patients were afraid to pick up a gallon of milk. Our young breast cancer survivors were afraid to pick up their kids because of this fear that they weren't allowed to do any kind of lifting. And when this study came out, it showed that as long as our survivors are engaged in a systematic, controlled exercise program, that strength training and lifting is not only going to not cause lymphedema, but it can prevent lymphedema from actually happening. So, I'll go back to this study over and over again to say that, this is, doing some sort of structured strength training, like you were saying, to fight off BMI, is definitely the way to go.
Thanks, Scott. All right. Do we want to take a quick break and check in with everyone? So I'm going to stop the share briefly here. Just want to check in with the group if there are any questions or thoughts on peripheral neuropathy or lymphedema so far. Maybe you have a story that you'd want to share. And feel free to use the chat as well. Okay, not hearing anything right now, so I'm going to jump back in, share the screen. Okay, so I'll turn it over to Maura.
Okay, hi everybody. So late effects do have a nutrition component, and as many of the dietitians out there already know, one is the late effects of treatment, what we call nutrition impact symptoms, which is really how does the treatments received affect the digestive tract. So it can affect it, and you can see that laundry list of ways that it can affect it. And all of it that would be obstacles for, it's just simply chewing and swallowing and other digestive issues. So every person who walks into Survivorship Clinic can present a different picture. But this is always, I always joke that this is my picture in my head when a patient walks into clinic, that I think of them in terms of their digestive tract and the treatments they have, and then it kind of directs my questions by knowing what treatments. But from beginning to end. And a lot of times people have pre-existing conditions prior to their diagnosis, and these conditions still exist. So a lot of my work is often non-cancer related, but just comorbidity related. But in the next slide, these are honestly my most commonly used therapeutic diets. My big job often is just changing textures to help chewing and swallowing, because as we know, when people have these difficulties, they end up eating very skewed foods. They end up, I only can tolerate Ben & Jerry's Chubby Hubby and, and pumpkin pie. And those are the only two foods I could tolerate. So my job is a challenge to say, well, let's expand on those. Let's not make those your only foods, but you got the texture right. So let's try to make sure that you're nourishing your body and getting your nutrients in. The next one is, I can't tell you how common GERD is as a result of treatment. And then also educating people on the importance of fiber. As we know, most people don't get enough fiber in their diet to begin with. So to increase their fiber, but also how there's different fiber and differentiating between the different foods, using your insoluble fibers to help treat constipation and using your soluble fibers for treating diarrhea. So people find this very enlightening. They don't make that connection. They don't know the difference. And the last one, many of you may not be aware of this one, but the FODMAP diet, which is, as I say, why they create acronyms, because it's such a difficult diet, but it's really an elimination diet of short chain carbohydrates. And this is helpful for people who are experiencing like dumping syndrome, either short or late dumping syndrome, and other various kind of lower GI intolerances. And people have success with this.
Or I'm wondering if you have handouts that address like GERD, the fiber sources, and whether they're soluble or insoluble, and the FODMAP. Do you have like?
I do. You know what I do is I have a whole library on file on my laptop, and I email it to them. I get their email address and I email it to them right during the session.
is each diet like hand out several pages long for patients to flip through, or is there like an easy 1-page thing that like you find to be the most helpful that might be helpful for this group?
Yes, well, for the FODMAP, Stanford University has a really good PDF. It's like a 1-page. That's helpful.
Okay.
The other ones, I actually get through the Academy of Nutrition and Dietetics. They have beautiful patient education materials.
Okay. Good.
So I think, yeah, we can put some of those resources up on the
Sure.
box and share that with everyone, whether it's a website to go to or the documents themselves.
So definitely put up the documents because
Perfect.
those are my highest use.
Yeah, that'd be really interesting to
Yeah.
take a look at.
Okay. Now this is a unique nutrition late effect, but that people actually become fearful of food because, as we know, a lot of times people don't know why they got cancer. And even those people who ate well and exercised, they still say, so how did I still get cancer? And it's very common to hear people say, something I ate must have caused my cancer. Or something I may eat or may cause my cancer to return. Because it's really hard to say, this is exactly what caused your cancer, this one thing. That's really not how we talk about it. So people come in trying to figure out, why did this happen to me? And it can end up in a very distorted view of food so that it becomes a fear of food. And my job is to turn that fear of food back into enjoyment of food. And that's often a challenge because people can actually lose interest in eating and lose interest in going out to eat with friends and family. And that's a terrible place to be. And then they actually you can start missing out on major nutrients. So a lot of that confusion and fear of food comes from this word cloud. It's kind of has a lot of the reasons why when people start trying to figure out why did this happen or how does food relate to my cancer, they go online and they come up with a lot of conflicting information. And so it's this confusion. So a lot of my distilling of the fear of food comes with kind of unbundling this misinformation. So it gets back to one of my favorite teaching points is that we really need to get to battle the non-evidence-based messaging that comes from team members that go to the patient. So a lot of this fear of food can be dispelled by having clear, consistent, evidence-based nutrition information imparted by all team members.
Oh.
We don't have Angela's.
So, forgive me.
Oh wait, I thought I saw it. Go back.
Oh, did it come up?
I thought I saw it.
Sorry about that. Let me just reshare.
No. What did I see? I thought I saw depression, anxiety. I guess
here,
I'm seeing
yeah.
things. Oh, that's
Give-
probably.
Give me one moment, little technical hiccup. Sorry about that, everybody.
Well, while we're clearing that up, does
Yeah.
anyone have anything for the chat room or any of their own stories about fear of food, anecdotes from patients? I often find for other clinicians that the concept of fear of food is kind of surprising. They don't think it goes that far. I don't know what you guys think here around the table.
I see it, I have, it's a patient example sticks out in my mind of a young woman who was pregnant when she was diagnosed with, unfortunately, metastatic breast cancer. And she had a healthy baby, and we started her treatment. And she decided that sugar feeds her cancer. So she cut out all sugar. And she basically ended up looking like a patient who has anorexia nervosa. She got like the hair that grows, on your skin when your body fat is too low. And, she was a runner to start with, but she really was running excessively and just avoiding all foods. And we had a lot of talks about this. And it ultimately, she did come off that it wasn't sustainable. And she, fortunately was able to enjoy food. And before she passed away, she had a normal weight for probably over a year. But it was very real and very tangible to her that she was convinced that that's what was feeding her cancer, and she was going to cut it all out. And she did for a little while, but she looked like a skeleton and she had no energy. And, I said it was going to impact how we treat you. And it was really difficult to change that tide, even though her medical team was saying, stop doing that. So it really, it's a fixed belief that is held normally outside of any medical reasoning, right? So you have your medical team, but patients are like, I don't care what you say. I'm sure about this, and this is what I'm going to do. And so that's what I think you see.
Yeah.
That they're not telling us. That's why probably a lot of the doctors and nurses and APPs don't understand how far it goes, because that's omitted from our conversation a lot.
I have a different patient. This is actually one of the HEMOC fellows that comes to mind, who is basically avoiding all evidence-based treatment. And she took out sugar, she took out gluten, she took out, you name it, milk, lactose products, and she's doing, high dose vitamin C and injections of mistletoe, and it's very difficult because she's actually a nurse. She has some medical training, and just having the conversations about even just treatment is very difficult. And I feel like because that takes so much time, it's even hard to get the direction back to food, because from our standpoint, like, where do you even start those conversations? And that can be really difficult.
Well, I think that's one of the advantage of a multidisciplinary team, where the patient gets, in our case, half an hour with the dietitian, where you can really just focus on it. And sometimes it takes a little time in the session, but then it starts coming up, and they get to really explain it. And that's where I always try to figure out, where is this coming from? Where are you getting it? Where are these beliefs coming from? Were you told this? Was this your own, own investigation? So even finding out what the source of it can be helpful. Sometimes they were told by somebody else, and they don't really believe it themselves, but they're doing it anyway. Versus they've researched this, and this is a very hard-held belief. That's more of a challenge, because that belief counts, right? So it's sometimes it's negotiable, sometimes it's not.
Yeah.
Just had a comment from Amanda up in the chat room. The fear of food is pervasive, and your antidotes resonate. Intelligence has little to do with fear.
Yeah.
So that's a very good point. The opposite is true, where patients see the dietitian as the shaman without regard to evidence-based medicine. So that's a very good point, Amanda. Okay. There we have it.
It's missing because we took it out from another echo that we did because Angela was not with us.
Okay, sorry about that.
Sorry about
Technical
that, everyone.
difficulties.
Thank you for your patience. So we're going to jump into this now.
Okay, so this is Angela with social work, and just due to the interest of time, I'm going to, talk about aspects of some of these slides, but with others, I'll just probably gloss over. But one of the late long-term effects for cancer survivors is depression and anxiety. And it's important to know that most cancer survivors actually adjust fairly well to life after cancer. But there are some who do experience negative mood, such as related fears, anxiety, and depression, and even some aspects of PTSD. But I will not be discussing that here. But also, with mood fluctuations, they may not reach the criteria for the clinical diagnosis of anxiety or depression. However, the symptoms can still interfere with a cancer survivor's quality of life. Also with, go back. It's okay. I'll tap you, okay? So with mental health concerns, it's really a prominent and unmet need of survivors, again, anxiety, depression, as well as cancer-related distress. And it's important that, survivors address these mood concerns, because they can definitely create barriers and disrupt the quality of life, as well as returning to usual activities. Okay, so GOATS in 2019 did a meta-analysis and a systematic review of 50,000 long-term survivors average was about 7 years out from diagnosis. 12% had depression, 18% reported anxiety, and then depression among survivors was 5 times higher than the general population. He also did a study himself and looked at 1,002 long-term survivors at 5 and 10-year marks. And again, the statistics are shown below what was found. Depression and anxiety are 17 and 9%. 87% had high anxiety with an increased level of depression. 46% had high depression as well as high anxiety. And this is more prevalent among people who are up to age 70. And then after 70, it was really no different from the general population. Okay, so these are some risk factors for cancer survivors related to anxiety and depression, young age, higher education, which I thought was interesting, financial problems, low cognitive function, concentration and memory issues, fatigue, sleep problems, loss of appetite, eye disease, and patients that were in a partnership. So that means like a relationship with a significant other. But also I want to note too that patients who have a history of mental health issues as well as trauma also are a risk factor for depression and anxiety. So I'm not going to go over this, but really this is just the diagnosis out of the DSM, the Diagnostic and Statistical Manual. Basically, for someone to be diagnosed with anxiety, they have to be experiencing at least 3 of the following symptoms that are listed below. For depression, it's experiencing at least 5 of the following in the past 2 weeks. Again, this is from the Diagnostic and Statistical Manual for depression. With late and long-term effects, I just want to point out that many of the symptoms for anxiety and depression will overlap with the other problems that cancer survivors may report, such as cognitive difficulties, fatigue, and sleep. So it can become kind of tricky to try and tease it out. And that's what I love about this multidisciplinary team, because we talk about the patients and all of us have a different perspective, and we're really able to look at the whole patient and try and figure out what exactly might be going on. And usually it's a combination of many things. Physical symptoms can be associated with depressive symptoms. Mood symptoms, again, can overlap with each other. Depression and anxiety often go together. And then most importantly, it's the majority of the research that's out there related to emotional needs of patients has been done on the breast cancer population. And so, it's just important to note that. That's actually a lot of the research that's out there, like with fear of cancer recurrence as well, is focused on breast population. And then you've seen this slide before. This is just from my perspective in the clinic. These are the things that I would talk to patients about, different referrals that I would make to, providers and services in the community. And that's it. Okay.
All right. Thanks everyone for hanging in there with that little technical hiccup. I wanted to open up the floor to everybody and ask if there are any questions or thoughts on the presentation from today before we get into other topics. I'm going to unmute everybody. And if anybody wants to chime in, feel free to jump in and go ahead and say something. Alternatively, there is the chat box. I know a few of you have already used it. Thank you for that. You can also chat in there. Okay, so nothing right now, crickets, but does anyone else from the team here have any thoughts on any of the topics, maybe any experiences? I heard you guys talking a little bit about some of the patient experiences.
Yeah, Angela, thank you for that overview. I think there was a long list of people who are at risk for depression and anxiety, and it, based on how different those risk factors are, it could be almost anybody, right?
Absolutely.
So like a young age or a higher education or a low socioeconomic status or a low cognitive, there's not a group out there that's not at risk.
Absolutely.
And, I think we see a lot of patients really struggle. That's why the Survivorship Clinic came into existence at all, because of people feeling so lost.
Yeah.
And that, I think that leads to a lot of feelings of depression, anxiety, maybe not clinically,
Right.
To the point where they meet DSM criteria, but we have so many patients who come through who just feel better talking about this stuff. And
Absolutely. Even the lovely woman that we saw today, she was definitely having some levels of anxiety.
Who
And
was she, or what was her story?
So,
So she had a history of breast cancer. She was on aromatase inhibitor, and she was struggling with a lot of anxiety from the side effects associated with it,
and taking the hormone.
and taking
estrogen.
originally the hormone replacement therapy she was on previous to her breast cancer, and she had a lot of fear of recurrence with regards to that, and concern that that could lead to an increased risk of recurrence. And so she had a lot of anxiety associated with insomnia and hot flashes. We counseled her on that, and I'm interested to hear maybe how your visit went.
Oh, well, I mean, it was just a lot of education, right? And normalizing what she's experiencing and going through is how most cancer survivors think and feel. And, you know, I did talk to her about, she did also say she was experiencing some loss of interest of usual activities, which that can be an indicator for depression. But as I delved in deeper with her, it wasn't like that it was preventing her from living her life and doing the things that to do, or preventing her from getting out, going to appointments or commitments and things. It was just she had noticed that this Christmas she's just not in the mood to decorate and really go shopping and make cookies and things, and that's different than usual. But she's been having a lot of other health issues, that not just breast cancer. So you know, I encouraged her to consider therapy. She's not quite ready for that yet. She just wants to keep an eye on it. You know, we talked about that if this gets worse or doesn't improve, that she could definitely reach out to me for that. But the insomnia was really bothering her. But it was interesting because she's getting about 5 to 6 hours of sleep, but having a hard time sometimes falling asleep and a hard time sometimes staying asleep. And so
She had another interesting aspect came up with this woman. She had kind of elevated LFTs, liver function enzymes, and but in like 2014, it was kind of an old finding. So she took it upon herself to start using milk thistle because she heard that helps your liver. All right, but it's directly contraindicated with aromatase inhibitors, but she didn't know that. So she was kind of chasing down this, you know.
She went down that rabbit hole.
She went down that rabbit hole of, well, I had look, then they weren't even really elevated LFTs. They were kind of like high normal, but it was brought up, and that kind of freaked her out.
yeah.
So, you know, and but she had a pretty steady alcohol intake. So, you know, and you know, it was a pretty steady daily, you know, when people report a steady 2 drink a day, it often can be higher,
Yeah.
you know, like, so, you know, so it's kind of like, you know, for LFTs, I think, like, I was like, let's stop the milk thistle, but let's like rein in the alcohol. And she was open to it, but it just goes to show how, you know, they're trying to figure it out.
So I was just going to say one.
So I just want to say this woman that we're talking about, I wouldn't diagnose her with anxiety, but she definitely is having some signs and symptoms that is impacting her quality of life. You know, definitely. So, but anyways,
Never a dull moment.
right.
We have a question in the
Got some great questions from Pam and Amanda. I'll just 10 seconds. I'll throw in my 2 cents from this patient for today. You know, Angela, you were talking about sleep concerns, and with all of her concerns, Jevin, that she had posed with the aromatase inhibitor. You know, we were talking about weight-bearing exercise, and you know, I was saying, well, you know, and she was saying, I don't know how intense is intense exercise. And so, you know, we were talking about, you know, tracking, you know, your heart rate, you know, with a lot of, you know, with the Fitbits or the Apple Watches or that sort of thing. And you know, a lot of these also now track sleep. So I actually showed her on my Fitbit.
Awesome.
I said, not only is it tracking my heart rate in real time, but it tracks my sleep, and it breaks it down as to like awake time, light sleep, REM sleep. And so she's like, oh, this is great. And I said, well, Christmas is a week away. So, you know.
And what I find about the sleep analysis on the Fitbits is that they'll compare your sleep pattern to your age, you know, population, your age, and it helps normalize a lot of sleep. Because as people get older, their sleep patterns change. And I'll say as a personal, you know, when I with my Fitbit, I thought, oh, my sleep quality is really going down the tubes.
Yeah.
And then when I did my Fitbit comparison, I was better than the average for my age, and I started sleeping better because I stopped worrying about it.
your sleep. But I want to make sure we get time. Two great questions. First, Pam, Angela, this may be more of a global question. You have resources you refer to for financial concerns or food insecurity.
So clearly local resources, we have a variety of programs available here at Yale at the hospital that I would refer patients to, just that would help, with like financial aspects of bills and so forth. Educating patients about getting on payment plans. Sometimes patients, maybe they're not working, and then, guiding them on how to apply for Medicaid or Husky here in Connecticut. Talking to them about resources that are available to talk to them about Medicare. There's different plans available and aspects to that. We, unfortunately, a lot of the financial grants that are available to patients when they're in active treatment. So chemo and radiation or just had surgery. And so it's a bit challenging, sometimes encouraging patients to go to like a financial planner. And then giving them, I do have the Department of Social Work here at Yale has a resource guide that has local food pantries and food kitchens that I can, give to patients. But also, if they aren't connected to like a food stamp program or something like that, or encouraging them to go to their local church, oftentimes they can get donations there. So
Great. And this is Amanda, this is a great question. I think this might be a great way to wrap up Echo 1.0 here. Overall question, in a perfect world, realities and barriers aside, would you continue with your current model of survivorship care? What would you change? And what would be your ideal model?
Wow, that's fantastic.
Amanda, who paid you to ask that question?
Do you want to move to Connecticut? Join our team.
So, I guess to start, coming into this relatively new altogether out of grad school, I had never heard of this sort of model being applied to anything, let alone survivorship care. So I felt very fortunate to be a part of the team. And I found that I would say, yes, I'd want to continue with the multidisciplinary approach. I think it's applicable, to be honest, across many different chronic conditions. Things like diabetes, for example, is a great example of that, where different providers and specialists can be a part of the team. And it's not limited to just us, as you see here, a medical oncologist, a registered dietitian, PT, and social work. It extends to other providers, and it depends on that population in that community. If there's an increased amount of patients who have cardiovascular risk, maybe having a cardiologist or cardio-oncologist on board would be beneficial. I know in the breast center, we always are talking with dermatology. We work with one of them very closely. So maybe having a dermatologist on board, if your skin cancer population is high. So I think it's unique to that, sexual health specialists and so on.
I think, I think that's a great question. I've been thinking about it myself as we move forward in Smilo and we continue to expand. Some things are becoming evident. You can't see all the patients, right? One day a week with a multidisciplinary team. So how do you make sure you keep this approach, but get every patient services that they need? And, I would love to see this continue and grow. There's other care centers within the state that want us to come and give services there. But I really do think we could expand to include meaning-centered therapy groups. I think we can include, we wanted to do cognitive behavioral therapy for insomnia. We're trying to get a cancer and cognition clinic up and running. We've always wanted to do cooking classes, couch to chemo. I think what I love about survivorship and what the challenge is, how do you get so excited, but we're a team of, the room is, right now we're like a team of 10, but, we have to build sort of this big umbrella infrastructure with lots of teams that, so that all the patients can get the services that they need. And then, Amanda, just to end my part of what I'm saying is, we need a much better, robust system to handle long-term survivors. And I think that that's a crisis that we're having. Is a good crisis to have within oncology, but we don't have room for new patients because we're still seeing follow-ups, and we need a better system to kind of help
shuttle them through to what I would like to see, a cancer-related internal medicine clinic.
And just kind of to piggyback off of what Tara was saying, Jevin here again, we work closely, for example, with our bone marrow transplant team, and there's something in the works to try to get more of an integrated model involved there too, so that they have the fallback option for the multidisciplinary model that we offer for survivors who would most benefit from that with more complex concerns and so on. So I think it's about being flexible with the resources that are available to you and really utilizing what's there to address the concerns of that population, even if it is specific to one disease type, and having an integrated model there.
So that's
Yeah.
beautiful.
I guess I'd like to see survivorship, the lessons learned in survivorship be actively integrated further upstream. And so like in the chemo suite, like having active exercise being done during chemo, like Scott often talks about treadmills in the chemo suite, that type of thing. I'd like to see much more expansion of survivorship lessons folded upstream into active care, and also to have more fun things in terms of nutrition and just of skill building. And I think there's a big need for that, and more group type activities, cooking classes, that type of thing. And I know Scott has a long list, right?
I have a very, very long list. I mean, obviously, if money were no object, of course, I'd love to have a survivorship wellness center in all of our care centers. And that would include, a mini gym. It would include a kitchen. It would include, like a labyrinth, or like a healing garden,
Mindfulness
that sort of thing.
meditation.
Right,
yoga.
absolutely. But I think, we've talked about it before. Maura, I know you've talked about this a bunch as far as just kind of the common themes that we can impose throughout the system. So if you have your think tank, right? We're kind of like the think tank here for Smilo, so as you guys go back, and you become you're the gurus of survivorship in your centers where you practice, to try to then take everything that you've learned and try to disseminate that throughout your healthcare network. The ideas of moving more and eating well, self-care, those types of things, kind of those common messages that we've talked about previously. Now you have the tools to do that. And so that's probably the best thing that we can impart on you guys, is that you can take that to your institutions and have that common theme go throughout for all providers.
Oh, well, I think all of you have really touched on, I think the one thing that comes to mind is, I will often refer patients out for mental health counseling. And it would be ideal if we had a clinic, a wellness center, where, we were seeing patients 5 days a week. And I had the capacity, if they chose to see me for some ongoing individual mental health counseling. And so I think, again, rooms to do groups and meditation, and but I think all of you touched on all of this. We've done this a lot, where we've brainstormed together, and
Obviously, we don't have an unlimited
That's
budget,
right,
otherwise we
that's
could do
right.
all this
Yeah,
every
absolutely.
day. Well, it's 3 o'clock.
Yeah,
Thank you so much to this group.
Yeah,
It's been amazing.
been absolutely wonderful sticking with us through this journey through some survivorship topics. We're hopeful that you'd be interested in continuing this in the future. I know we didn't get a whole lot of chance to go over specific suggestions or future topics, but I will be sending out that post-clinic survey. Please do fill that out at the bottom if you want to include any suggestions, topics to consider for the future. If you think this would be useful for another group coming in even, that would be absolutely wonderful.
I would strongly encourage and plead with you to please give us your honest feedback about how this went. This is our first time. We couldn't have done it without everyone here, but especially Ashley and Jevin really took the reins and designed the curriculum. What worked well? We want to hear about that. What do you wish we would have covered differently or omitted? because, you know, we want to keep an echo presence going. And thank you so much for participating. And now we just need to hear from you what your opinions are.
Absolutely. And, you know, again, thanks everyone for taking the time with us. We enjoyed seeing you, hearing from you. We're hopeful to hear and see from you more in the future. So stay tuned. This is just the beginning of the journey, and we're hopeful to see you along for what the future holds. Thanks, everybody. Happy holidays.
Happy holidays.
Thank you.
Bye-bye. Bye.